So what is forensic psychiatry? Some people would say that it's the branch of psychiatry that sort of interfaces with the law. We have a bunch of people who society don't necessarily want to talk about or think about because it's very easy to sort of stigmatize other people and to label other people crazy or you're evil.
Anxiety, depression. How have you seen that 2020 has affected people?
So I think what we're starting to understand more about psychopathy is that there is a neurobiological, neurodevelopmental sort of component to it.
What do you think of Hollywood's interpretation of psychiatric health?
Truth can sometimes be stranger than fiction.
Hello, everyone, and welcome back to my series, More Than a Doctor, where we interview doctors who perhaps have side hustles that have become their full hustles, and doctors who have maybe gone down the less traditional career path. And today we are joined by Dr. Bernard Chin. He is a consultant forensic psychiatrist. So, Dr. Chin, introduce yourself and say hello.
Hi. Most people call me Bernie. I'm a consultant forensic psychiatrist, I think. And as Jessica said, it's probably the route less traveled. There's not that many of us in the country. We look after people, or very specific people, who I think we'll probably talk a bit more about as we go on.
Yeah, so the viewers are definitely very interested in finding out exactly what the job entails and also what psychiatry is like as a job, because as we know, there's such a need for mental health professionals, but there is a gap there. So firstly, let me ask you, what is forensic psychiatry?
So that's a very interesting question, and one that I very often pose to my trainees and to medical students when I do teaching sessions. So what is forensic psychiatry? Some people would say that it's the branch of psychiatry that sort of interfaces with the law. So we do a lot of things in court with the police and help people who, I suppose, are going through a court case because we have some level of training with that side of things. But I suppose I would see it as more or less the branch of psychiatry that looks after people that perhaps other people struggle with, that are a lot more complex, probably a lot more risky in their sort of behavior or in their actions because of the mental health. They might have sort of gone through the criminal justice system, and we sort of support them through that and help them come out the other end to reintegrate into society as much as possible. I think what drew me to it really was that we have a bunch of people who society don't necessarily want to talk about or think about because it's very easy to sort of stigmatize other people and to label other people with terms and names like, you know, you're crazy or you're evil, and, you know, we park them aside and don't think about them ever again. So it's the job of people like me and the people I work with, including nurses, psychologists, OTs, everyone, to actually think about the things that other people don't want to think about. For instance, if someone had committed a homicide at some point in their lives, what led up to it, what was the circumstances, what did the victim represent, and trying to repair the damage that's been done in the perpetrator's psyche, and also to think about where would they fit in society now after they've done something so horrific like that, and how to sort of safeguard the rest of society to ensure that things like that don't happen again, especially from this individual. So there are various components to that work, I suppose, but that's the gist of it.
Okay, so to look after a group of people, as you said, are kind of forgotten about by society, and what their role going forward perhaps looks like if that is available to them. So what does a day or a week look like in your career?
So at the moment, I work in a community team. So forensic psychiatry works quite rigidly in terms of you've got people that are based in prisons, You've got people based in sort of police custody suites and in courts to help sort of risk assess very quickly and to determine if they need to come into hospital. In prison, we sort of provide sort of medical input to ensure that, you know, people who do come into prison do get support for their mental health, because prison's not a very nice place. And a lot of people will require some mental health support. Not everyone needs to come out to hospital, but we will provide sort of in sense what we in reach. So team based in prison going into the wings to see people and support them. But if we can't manage that in a prison setting, then they get moved out to secure hospitals. So people probably would have heard of Broadmoor and a few others of like the Bethlehem Hospital. So those are very sort of historical, very big names when it comes to psychiatry and forensic psychiatry. You've got doctors in there sort of looking after people who have committed quite big offences, and we would sort of, you know, treat the mental illness, try to sort of figure out, you know, what led to the offending, and sort of secure some sort of journey out for them, which is where I come in. So my team works in the community. We help people transition from that hospital or even prison life back into society, and to help them with their recovery. If you think about someone, for instance, who's been in hospital for maybe 10 years or 20 years, 10, 20 years ago, you won't get a lot of things that you do now, you know, with, for instance, Apple Pay, or just, you know, using a credit card to tap on something. So you have to sort of retrain them in terms of how to engage in society again, and help them sort of through that journey so that eventually they can achieve some sort of normality. From a, I suppose, public perspective, we also have the responsibility to supervise and to ensure that, because these people have committed offences before as a result of the mental illness, we want to ensure that that doesn't happen again. So we work in collaboration with various agencies, including the police, probation, schools, local authorities, Ministry of Justice, to supervise, to ensure that the public's safe at the end of the day. So it's very much two-pronged. We look after the patient, but we also ensure that the public is safe, which is quite odd in medicine, I suppose.
Yeah, and does every offender get a mental health review?
So it depends. So if there's any issue with regards to someone's mental health, they might get an assessment. And if it's determined that the offending behavior or the offense that have brought them into sort of custody in the first place have some sort of involvement with mental illness, or there's some sort of direct link, then they'll get a mental health team. Sometimes some people's offending behavior has nothing to do with their mental illness whatsoever. Very often people may develop some sort of mental illness in prison, be it depression, be it anxiety, or even psychosis. That can happen. And then they get transferred out of hospital, and we also look after sort of people with sort of that profile. I suppose with those, we would work more closely with probation and with the criminal justice system, because although they have a mental illness, the offending behavior and the criminology side of things it predates that. So there isn't necessarily that connection. So we work with probation to monitor and supervise while providing support for this person's mental health.
Okay. And is it a dangerous job?
Not necessarily, I don't think. I get asked this question quite a lot, and I think we know our patients quite well. We know ins and outs of, you know, their history, their background, the signs of when they're becoming ill or when they're becoming a bit more irritable or agitated. And I think we rely on gut feeling quite a bit. So if it's something that not a lot of people can explain, we call it relational security, that we know someone so well that we know when something's a bit off. We can't necessarily tell what it is. It might be that it's something that it's innocuous, like you walk towards a person's door and usually they'll leave something out because they like birds or something. They'll leave a bit of food, and today they just haven't done that. It's a Tuesday, and they always do that on a Tuesday, and you go, that's a bit funny. So you become a bit more aware of your surroundings, and you start asking a lot more the questions about what's happening, what's going on. And we try to safeguard staff as much as possible. So if there's any indication that someone's not being very forthcoming about their mental state, we say, okay, why don't we do a 2-person visit instead? And we have other things to ensure our safety, like check-ins and sort of code words when we use the phone to say, if I'm ringing the team and saying this, ring the police for assistance immediately.
That is the nice thing about psychiatry, is that you get to know your patients really well on that type of personal and intimate level. Like, I personally believe no other specialty really can. And also in terms of offenders or people with mental health, often they're more likely to harm themselves rather than anybody else as well. And I guess that compassion that you guys have is really admirable. So if we go back and go back to when you were in medical school, what was your journey like into medicine?
So medicine wasn't my first degree. I did my first stint in University of King's in biomedical science, actually, and I sort of dabbled in psychology at the time. So predominantly it was all, physiology, etc., molecular biology and genetics. So I focused on genetics and sort of minored, if you will, in psychology, and really sort of loved behavioral science, and sort of graduated with a biomedical science degree focusing in genetics and psychology, which is odd, and thought, okay, I'll go into medical school, and actually went to George's. So I'm a George's boy. And I think if you look at the league tables and everything, George's has always been one of the biggest producers of both GPs and psychiatrists. So here we are. I think into probably year 3, which would have been T year for you guys now, I did some what do you call it now? Sort of special study components.
Yeah, SSC.
We called it SSMs back in the day. I think you would call it SSCs now. And the first one I did was psychiatry and film, which I think is still one of the projects that's running at the moment.
Yeah, I think it's psychiatry and art, but of course that's including film, yeah.
And the supervisor I had was a forensic psychiatrist. He was the registrar at the time. He's now a consultant, and I still work with him, and so remind him that, back in the day when you were a reg, I was a student, and he sort of tells me off for making me feel old. So that sort of got me interested in psychiatry, and then sort of, I think in my final year, I did an elective in the Bethlehem and in forensic psychiatry. And sort of fell in love with it, with, I suppose, the practice and the compassion that the consultants had for the patients that came through their wards, and how they really got to know the patients and the service users, and how it was a lot more collaborative. And I think one of the other things that really attracted me to psychiatry was how you can see someone or 5 people with schizophrenia, and they all present in very different ways. And it's about their journey, their narrative, and helping them through sort of the difficult times and making sense of what's happened to them, that I think really drew me into psychiatry. So that's sort of medical school, sort of omitting all the other sort of drunkenness and parties.
Okay, so you always had your eye on psychiatry then, basically.
Yeah, I think psychiatry was always going to be sort of the trajectory. And I think coming up to 4th and final year, myself and a bunch of sort of other like-minded people started the Psychiatry Society in George's, and that sort of solidified the trajectory. And then I went away to the north to do my foundation training. I did psychiatry in my F1, and then applied for core training in South London, and sort of from there on tried to do forensic psychiatry again, and decided actually I still enjoy it, I still love it, and applied and got in, and now I'm a consultant.
Amazing. And what would you say is the best thing about psychiatry?
I think, like you say before, we really have that opportunity to get to know the patients, and I think it's purely because there is no other way of practicing psychiatry other than taking a really good history and seeing, what their experience is, their narrative, their background, and everything else that contributes to why they're presenting to you at that point in time. And you hear stories which are harrowing of, discrimination, racism, trauma, and how sort of they've experienced all of that and so still come out at the other end, although needing support from us, but still resilient enough to still be standing.
Wow. That's interesting. I've been watching some YouTube videos on trauma, one on racial trauma actually, and Black women's mental health, and I've done one video on BAME women's mental health and the disparities there and the different challenges. So that's interesting that you just brought that up. And what is the worst thing, would you say?
Well, I think there's still ways to go in terms of our practice. We're not necessarily, well, this is my personal sort of thoughts and things. We're not practicing psychiatry as how we should be. And it has to do with a lot of resources, a lot of time. And I'm pretty sure if you're on your GP placement right now, GPs will be telling you sort of spending 8 minutes with a patient is ridiculous. How can anyone tell you all the problems that they need to be fixed in 8 minutes? And similarly with us, although we have that hour to spend for the initial assessment, there's always a push because, like you say before, mental health is a topical subject at the moment. And with COVID, a lot of people's mental health is suffering. And there is more demand than there is supply, I would say. And with an organization like the NHS, there's always a push for a lot of things that we have to do, that we don't enjoy doing, like paperwork, like performance indicators, and everything else that takes up time that you lose, sort of having that face-to-face contact with your patient and trying to sort things out. So I see that actually the worst thing sometimes is knowing you can do so much more, but being limited by the amount of resources that we have. For instance, having not enough trainees in psychiatry, not having enough consultants in psychiatry.
So in terms of 2020, people's mental health, in GP land, I'm seeing this, that there are a lot of people coming in, more people with anxiety, depression. Yeah, how have you seen that 2020 has affected people?
I also run a service that provides support into police custody. And from what they're saying is that we're seeing a lot more people coming through police custody with mental health difficulties because of the COVID lockdown. A lot more people who are sort of already receiving mental health support, struggling because of the COVID measures interfering with their ability to see their care coordinators or their psychiatrist face to face. So they struggle and they have sort of quicker relapses, and they come in via sort of ambulances, and sometimes they come in via police because of sort of domestic violence and that sort of thing. So I think 2020 is just generally not a good year for anyone. Fingers crossed things get a bit better, but I think we need to prepare for the worst.
Yeah. And domestic violence has gone up during this lockdown period. So that is really tragic. One of my questions is, do you believe all crime has a psychological component to it?
I suppose in one way or another, that's a correct statement in the sense of if you look at it from a legal point of view or from court, you have the actus rea, which is the act of the crime. Your evidence points to crime happening, and then you have the mens rea, which is, for lack of a better definition, the intent. And the intent is from the cognition, the thought of, either premeditation or the rationale for why you did what you did. So there's almost always a psychological component to criminal behavior or sort of offending behavior. Sometimes some people would see it as justified, and that could be from their own sort of worldview. Some people have what we call violent ideation, or they're more likely to act out in an aggressive way to defend themselves, and they see that as justified. And that could be what we call a cognitive error, or that could be actually what they subscribe to, is a worldview that they subscribe to because of what they're exposed to growing up and what they're taught and what they've kind of pieced together from their own experiences in the world, that if you don't defend yourself, no one else will. So I think there is a lot of psychological component into why people do the things that they do and end up in the criminal justice system.
Okay. Have you ever doubted the psychopathy of a prisoner?
So psychopathy is a very interesting concept. I think the widely accepted thinking around psychopathy is that it's a personality disorder or personality issue. It's not a diagnosis as it exists because it's not within DSM or ICD or any of the diagnostic criteria, but it's sort of widely accepted that antisocial personality disorder is or psychopathy is a type of antisocial personality disorder. So I think what we're starting to understand more about psychopathy is that there is a neurobiological, neurodevelopmental sort of component to it. So it's a bit more like autism. And actually what we seem to see is that there might be two types, if you want to call it that, of psychopathy. One is something that you sort of are born with, and one is something you sort of develop as a result of your environment and your upbringing, which is probably a bit closer aligned to personality disorder and the antisocial bits. And I have had several people that I've worked with within sort of prison, and also currently on my caseload, who do sort of fulfill that criteria. Quite charming, quite sort of driven by boredom, wanting to do things that's very adrenaline filled, don't necessarily think of the consequences, don't really think about anyone else. And they can be quite challenging to work with, but they can also be quite interesting, quite exciting to work with. So yes, I have had sort of experiences with that. And I know a lot of people are very fascinated by it because, you get cinema and Hollywood doing a lot of stuff on psychopaths and the intelligent sort of criminal mastermind that doesn't always sort of correlate with reality, fortunately.
Yeah. What do you think of Hollywood's interpretation of psychiatric health?
Truth can sometimes be stranger than fiction. And occasionally Hollywood doesn't necessarily get it right, and sometimes they could actually downplay it. The last film I was quite interested in was actually The Joker.
Oh yes.
And it's sort of very stark and potentially honest depiction of mental health services in America. And I'm not going to say anything too controversial with regards to that, but the last few times I've been in America, you can kind of tell that they really do need more sort of mental health provision. And it sort of highlights almost as a warning to us in terms of what would happen if we don't properly fund the mental health system. And if you ask me, sort of, the Joker in that particular iteration isn't mentally ill. He was very aggrieved and he was let down. But the reason for why he did what he did in terms of that, no spoilers to anyone.
If they haven't watched it by now, then
it wasn't anything to do with psychosis. It wasn't driven by mental illness. It was driven by a lot of anger and by a lot of trauma, I suspect.
Fine. Okay, so your interpretation is that the Joker is not psychologically unwell, he's just angry.
Well, I suppose he was psychologically unwell from that sense, but not necessarily mentally ill. And I make that very clear distinction in terms of, I suppose, from a Mental Health Act point of view, mental illness, as described, as things like severe mental illness, like psychosis, where
Mm,
you lose the ability to either sort of distinguish between reality and sort of your internal world. Because you can say, someone with personality disorder can be very disturbed, can be very distressed about their experiences, but still maintain that level of um, control, I suppose, and understanding of their reality. So they're not
yeah.
out of touch with what's going on. They still know what's going on, but they're motivated to do something based on distress experiences and psychological damage and trauma.
Okay, that has actually made it much more clear to me, because I remember when on my psychiatry placement, I got the opportunity to go to Broadmoor, and I was just thinking, well, this is not fair, because every like most offenders probably have a history of when they were a child witnessing domestic violence, abuse, etc. Like, but you can be, that's, it's not denying the fact that they're psychologically unwell, but it's about whether their crimes were linked with being out of reality or not.
Yeah, and I think the courts are starting to see a lot more of that nuance. So they've recently published the sentencing guidelines for mentally disordered offenders, and judges are taking into account more of an individual's mental state and their culpability. So there is a bit more understanding about, what that mental illness has done to that person at what they call the material time, and what contributory factor the illness has played in that offence. So I would often be in court and get asked, doctor, what is this person's level of insight? Are they aware that they have a mental illness? Do they know that if they stop taking their medication, that they become very paranoid and they start believing things that aren't true? So very often I would be at court saying, well, this person in this particular instance has never understood the belief that he's got a mental illness. He believes what's happening to him is completely real. And he is experiencing things as if he's real. He's hearing voices. He's believing and seeing and knowing factually for himself in his own world that demons are possessing him, and he has to do something about it. So that would drive his culpability for what he's done sort of much lower than someone who, say, for instance, is aware of what's happening and is doing something impulsively, for instance.
Mhm. Another viewer has asked, do you think that the prison rehabilitation system is working? They've said psychologically. Is psychologically working?
The prison system is quite complex in terms of in the UK. I don't think, again, this goes back to resources and funding. Um, Prison services are something that I guess the general public don't really want to think about. And we still have a very, for lack of a better description, a very punitive approach to prisoners in prison and criminal justice system. If you look at a comparison study between the UK sort of criminal justice system or prison system versus the Nordic prison system, where the Nordic one is a bit more focused on rehabilitation, on sort of getting prison officers who are also social workers in to sort of try to rehabilitate and try to, re-educate the prisoners and get them back into society, then their model sort of on paper works better. But I guess we have a bigger population than Norway, and the culture is quite different to ours. So arguments against that idea is that you can't really base one country's model on another. But I would say that we still have a long way to go when it comes to sort of the prison service and what it actually does. We know that locking someone up for 20, 30 years doesn't necessarily prevent them from doing something else if you let them go after 30 years, because you're locking them up and you're not really providing an alternative. At the same time, you can say that actually one way of managing that risk. Aside from, if you let them out after 5 years, there's still going to be a risk. So you waited out for 30 years. I guess that's a very simplistic view of looking at things. What we've been trying to do, I suppose, with the NHS is to provide that psychological input. So we've got psychologists going in, managing a lot of the trauma, a lot of the other sort of undiagnosed conditions like ADHD and autism that we find in a lot of the prison population. And we try to sort of identify and mitigate as much as possible. So if someone gets into a lot of trouble because of repeated burglaries, because they're very impulsive, and actually in prison we identify that they have ADHD, if we can sort of treat them and see if that does anything, if that works any better. But that's, I guess, one component of it. If you then sort of release them without any follow-up, or don't give them opportunities, don't sort of teach them a skill, that, they're not going to have a lot of opportunities coming out because no one's going to hire them. They don't know where to go for supports, and people go back to what they're used to, which is criminal behavior. So I think we need sort of a well-resourced, well-funded, and sort of closely knit social service, mental health service, prison service, public sector, essentially. We'll get there eventually, maybe. We'll see.
Hopefully. Do you find that your clients work with you? Are they quite difficult, or?
I suppose it depends. Some people do, and some people find it very difficult. And we do have, I suppose, for lack of a better description, ways of compelling. So people can be detained under the Mental Health Act in hospital, and upon discharge, they can be conditionally discharged with still supervision by our team and by the Ministry of Justice. So they have to conform to certain conditions, such as you have to take your medication, you have to work with us. If not, then you risk being recalled back to hospital. And people might choose a pragmatic approach where they engage with us purely based on those conditions. But we hope to sort of work with them and build that rapport to a period where we can compromise and say, look, the conditions are there, but we really just want you to work with us so that you can take responsibility for your health, essentially. I think it's more difficult for someone who never achieves insight into their illness and don't believe that they're mentally ill.
Okay. And as we have said, 2020 has been difficult for many. Also, psychiatry is a branch of medicine that there is a higher demand than there is supply. So one viewer has asked, how do you maintain your sanity and mental health?
So I think you have to have a hobby.
And your hobby is?
Well, I am an avid sort of gamer, so I shut off by just playing video games or watching sort of funny things on Netflix. You have to at a point turn off, because if you don't, then you would be completely swamped by the realities of everything that's happening within the NHS. One of the latest things is Priadol, which is one of the main manufacturers of lithium, which is a mood stabilizer used for a lot of patients with bipolar. Priadol has been bought up by a separate company, and they're discontinuing that particular brand of medication and essentially upping the price of the replacement, which is going to severely affect anyone on it, because they have to be swapped over to this new product, which is more expensive and which will cost the NHS a whole lot of money. And what we know with lithium is that it does depend on the composition of the salt. So Priadol is slightly different to some of the other brands, and it can lead to relapse if we're not careful. So everyone has to find a way to relax, not think about these things outside the office.
Okay.
Otherwise, it'll be a lot of hair tearing, a lot of head banging, a lot of swearing, and a lot of petitioning government, and potentially even sort of civil disobedience.
Okay, so what you said, to maintain mental health as a psychiatrist or just any doctor and as a person, is having a hobby and knowing when to switch off.
Yeah. And I think what we do very well in psychiatry is we have peer groups. So we have sort of consultants who meet up every few months just as a safe space to talk about either cases that we're working on, so that we can sort of peer review our sort of practice, and also to vent and rant a bit about difficulties at work, be it patients, be it management, be it colleagues, be it anything, because I suppose things are getting far more complicated now, and we have to deal with a lot more in a lot less time.
Mm.
And COVID is certainly putting a strain on everyone. So I think we need to look after ourselves.
Definitely. Yeah, at the GP that I'm doing my placement at now, we have coffee meetings. So that's 12 o'clock every day. We just talk about the cases that are a little bit difficult, maybe if there's any type of social element to it that needs to be considered. And then they can ask each other for advice, or, you know, what would you do if you kind of thing. So that is very important to have a support network as well. So thank you very much, Bernie. That was an amazing interview. It's really just solidified the importance of psychiatry and forensic psychiatry and compassion for all our patients, and just understanding that time needed to analyze each patient and do what's best for them. So do you have any final words, and where the viewers can find you?
Well, come to the dark side. It's very exciting work to do. I would sort of support any medical student who wants to do a bit more to sort of go to local medical schools to ask about, you know, can you do a bit of a day in forensic psychiatry? That this very often you know, visits to Broadmoor, and even for foundation trainees who want to do a bit of psychiatry, go to your local providers and say, yeah, I just want to do a taste a day. We're all very friendly. We don't bite. We have cookies. And yes, I mean, there's a lot out there that you can read about. The Royal College website, the forensic psychiatry has a faculty. There are conferences, there are debates, there are webinars and things to that effect. So, you know,
Wow.
you can
What's that website called?
So it's the Royal College of Psychiatrists. And if you just go to the forensic faculty, they have a list of things there.
Amazing. All right then. So you heard that all. Make sure you go check out the Royal College of Psychiatrists. If you like this video, comment down below what you've learned, and subscribe so you can see the next episode. Thank you very much, Bernie.
Thank you for having me.